Hello and welcome to our critical analysis on COPD with our patient Cecile, presented by Group 5, the best group. COPD is characterized by persistent airflow limitation that is usually progressive. It is associated with an enhanced chronic inflammatory response in the airways and lungs and caused primarily by cigarette smoking and other noxious particles and gases. Smoking is the most common cause of COPD, although it can also be caused by a person's occupation, their risk for infection, or their age. Toxins in cigarettes damage the lungs by damaging the alveoli, and working in environments where people are more exposed to pollutants, such as diesel exhaust, puts them at a higher risk of developing COPD than workers who are not exposed. This is because narrowing the airways weakens the lungs' defenses against infections, causing swelling in the air tubes and destroying the air sacs, all of which contribute to COPD. Patients with COPD have an increased risk for infections like pneumonia because they have difficulty clearing their lungs of bacteria and harmful pathogens. Therefore, infection can exacerbate the disease. Age is also a risk factor for COPD patients because the changes in their lung structure and respiratory muscle may worsen or weaken as they get older.
One of the diagnostics for COPD is a spirometry or PFT test. In this test, a patient exhales forcefully into a tube that is connected to a machine. The machine will give a reading of the patient's FVC and FEV1. And based off the results, a physician is then able to assess and diagnose the severity of the COPD. Another diagnostic that can be used for COPD is the COPD Diagnostic Questionnaire, also known as a CDQ. This is a selection tool used to assess if spirometry testing is needed for at-risk patients. And this diagnostic questionnaire has a total of 14 questions. Some of the questions include, what is your age in years, what is the total number of years you have smoked, and do you have or have you had any allergies? Another common diagnostic tool used in the diagnosis of COPD is the chest X-ray. The chest X-ray can support the diagnosis of COPD by producing images of a client's or patient's lungs. For example, in image A, you have a normal lung. However, in image B, this is a lung that has COPD.
When visiting with a patient, it's important to gather data such as their health history and vital signs. This would aid in the development of a health-promoting care plan as well as the establishment of baselines. The sputum culture is useful in determining the presence of infection, and collecting ABGs would aid in determining the level of oxygen in his blood and whether or not carbon dioxide is being eliminated adequately. A spirometry test would assess lung capacity and function, which may help track the disease's progression. To assess symptoms of shortness of breath or persistent cough, X-rays would create an image of the lungs.
Patient outcomes were based on the assessment and diagnosis of the patient to ensure that long-term and short-term goals were patient-centered, measurable, and realistic in the care plan. Furthermore, we included the social determinants of health, such as income, education, employment, housing, social exclusion, social safety networks, and health services for the best plan of care.
Now it is time to jump into our case study. This case study includes a 73-year-old male patient named Cecile, whose occupation was a railroad engineer but is currently retired. His relationship is that he is married and has a wife. Health history includes that he was a chronic smoker with a 30-pack-a-year history and has hyperlipidemia and hypertension. His current medications are lisinopril, furosemide, atorvastatin, and metoprolol, which are used for his hypertension and hyperlipidemia. Our early assessment of the patient showed that he had a high oral temp of 38 degrees, an SpO2 rate of 83%, and was coughing up greenish-yellow sputum. This led to the diagnosis of COPD exacerbation, and current interventions are continuous O2 therapy at 2 liters via nasal prongs and new prescriptions for albuterol and fluticasone for his COPD. During our first visit with the patient, we completed a baseline assessment and vitals. The patient complained of ear sores and tubes tangling due to the O2 tubing. 2 weeks later, Cecile had stopped smoking but had an episode of dyspnea and anxiety, and his wife found him in the kitchen with shortness of breath, and he was unable to reconnect his O2 tubing. Occupational therapy was called, and the patient was referred to a pulmonary rehabilitation program. The patient continued with smoking cessation and was able to manage episodes of dyspnea much better. The patient did have a cold and sounded congested due to his sick grandchildren visiting. After that, the outcome of the patient ended up with us calling 911 to take him to the ER. Cecile experienced an episode of pneumonia, and that was followed by an acute respiratory failure and sepsis, which left him with residual neurological deficits. He is eventually medically stabilized and discharged to a long-term care facility.
Upon assessment, the patient stated he was scared and worried. For the objective data, his temperature was 38.6 by mouth. There was obvious respiratory distress utilizing accessory muscles. He was coughing yellow tinged sputum. His respiratory rate was 34 breaths per minute. His oxygen saturation was 90% on 2 liters nasal prongs. There was decreased appetite, decreased urinary output, and weakness noted. His wife also stated that he hasn't gone out of his chair in days. This is very concerning and abnormal for Cecile, as this can be an infection or an exacerbation of his disease.
The three main nursing diagnoses based off the patient's signs and symptoms are as follows. The first one, and most acute, is ineffective gas exchange as evidenced by shortness of breath, dyspnea, accessory muscle use, and problems in using their O2 tank at home. The second one is impaired ADLs related to functional decline as evidenced by new feelings of anxiety, decreased independence, and limited mobility. The third one is inadequate education about proper infection control as evidenced by sick children visiting.
For long-term goal number 1, we want the patient to report an improved exercise tolerance and activities of daily living while at the long-term care facility in 3 months. The goal is to help him not feel out of breath when participating in exercise and activities of daily living, as he has stated that he had some troubles. He was referred to the pulmonary rehabilitation program. As nurses, we will consult with the health professionals in charge of the program and communicate our goal and expected outcome with exercise conditioning. Our expected patient outcome is that the patient is able to perform activities of daily living and exercise without feeling short of breath.
The first intervention for long-term goal number 1 would be about medication education. Since the patient is on 2 different inhalers, I would educate on how to use both inhalers, ask for a demonstration back from the patient, as well as explain the side effects from both inhalers. The next interventions relate to proper oxygenation. Since the patient needs to keep oxygen levels at around 88 to 90%, we would put the patient on a nasal cannula and keep a 2-liter flow rate. I would also teach the patient how to test airflow against their cheek if shortness of breath occurs, as well as positioning the patient in high Fowler's or semi-Fowler's positioning or tripods, which helps in opening the airway and allows for proper gas exchange. These last interventions for the first goal focus on breathing, such as teaching the patient how to do pursed lip breathing, as it aids in proper gas exchange and expelling CO2, as well as encouraging coughing and deep breathing to loosen secretions, and smoking craving management, as well as involving the interprofessional care team such as psychologists, occupational therapists, and respiratory therapists so that they can work on different needs of the patient. Smoking craving management is extremely important as it directly relates to the social determinants of health of healthy behaviors and coping skills, as many people do use smoking as a coping mechanism, which our patient may have done in the past. Some best practice guidelines include referring the patient to a smoking support group, whether that's on the telephone, one-on-one, or group counseling, following up with the patient and creating new coping mechanisms with them, as well as nicotine replacement therapy, whether that's patches, sprays, or gums, as well as remembering that as nurses, we need to know that relapse can occur during the first 3 months, and reviewing the patient's progress and reason for relapse is extremely important, and from there we can revise the care plan with the patient to see what is and isn't working for them.
For long-term goal number 2, we want to prevent any infections or sepsis from occurring during the patient's stay at the long-term care facility, as he has experienced some sepsis and he had an oral temperature of 38.6 degrees Celsius and a respiratory rate of 34 breaths per minute and a yellow-tinged sputum, which indicated an infection. This goal will help prevent infections from occurring again, as he is susceptible and it could worsen his condition. To implement interventions, we will monitor for any signs and symptoms of infections, and our expected patient outcome is for the patient to demonstrate behaviors that minimize the risk of infections and for the patient to experience a few to no respiratory infections.
Interventions for our second long-term goal include continuous monitoring for signs of infection such as fever, high heart or respiratory rate, and elevated white blood cell counts, as well as teaching patients to take antibiotics for the full course, and for us to continually assess the need for a higher or lower rate of the O2 therapy, as well as encouraging the patient and wife to receive annual influenza, pneumococcal, and COVID-19 vaccines to prevent further infections from occurring. Patient education includes proper hand hygiene, teaching the signs of infection such as fever, chills, or sweating, proper cleaning of respiratory equipment, antibiotic adherence, the importance of adequate fluid intake, and teaching the patient to avoid visitors if they or you are sick.
For the short-term goal, we want to minimize the discomfort of oxygen administration equipment and the frustration of long oxygen tubing within 1 week, as he complains of sores behind his ears and reports that the long tubing gets caught around everything, and this goal is to help minimize the discomforts with oxygen therapy. We will implement nursing interventions by providing the patient with different options and alternatives for the long tubing and ear sores. The expected patient outcome is that the patient will experience little to no discomfort with oxygen therapy equipment, and the patient will not experience complications with oxygen therapy tubing.
Interventions for the short-term goal relate to minimizing O2 tubing discomfort, so we can apply padding to the tubing that goes around the ear to reduce skin breakdown. We can clip the O2 tubes to clothing to reduce tugging or twisting, or adding a swivel connector, as well as skin breakdown prevention such as using moisturizer or antibacterial ointment when skin breakdown occurs, and assessing the potential to switch to a portable O2 tank.
When measuring the effectiveness of our nursing care, our first intervention was effective because Cecile has continued to not smoke and is doing well with managing episodes of dyspnea. This is because he was referred to an OT to learn how to accomplish his task in the most energy-efficient way possible, and we also recommended him to a pulmonary rehab program. Cecile sounded congested, and his grandchildren all had runny noses when they visited him, so our second intervention was ineffective. Cecile is at a higher risk for infections due to his COPD, therefore we did not stress the importance of infection prevention with him. Our error was not teaching proper hand hygiene, signs of infection such as fever, chills, diaphoresis, etc., proper cleaning of respiratory equipment, and avoiding visitors who are sick. However, after implementing interventions and alternatives such as putting padding or using ointments like barrier cream, our third intervention was effective, as there was minimal discomfort and no voice complaints. Cecile would not have had pneumonia followed by acute respiratory failure and sepsis if we had educated him about the importance of infection control and how COPD patients